This is your video lecture for Chapter 36 out of your Modern Dental Assisting book, Moisture Control. The sources of moisture include water, saliva, the gingival fluid, and blood. Oral evacuation systems. Our objective is to maintain an intraoral environment that keeps the operating field free from excess water, saliva, blood, tooth fragments, and excess dental materials. We have two types of evacuators that we most often use during the dental procedures. They include our saliva ejector and our high vacuum evacuator, or HVE. Our saliva ejector is a small straw-shaped oral evacuator, and we use this during less invasive dental procedures. So our indications for use include preventative procedures like our propy, fluoride treatment, and sealant placement, control of saliva and moisture accumulation under a dental dam, and when we're cementing a crown or bridge, and then orthodontic bonding procedures. We're going to bend and shape the saliva ejector for stationary placement. We can position the ejector under the tongue where most fluids accumulate, or position the ejector opposite side on which the dentist is working. Our HVE is used for most dental procedures, especially when we're using the dental handpiece. Our indications for use include keeping the mouth free of saliva, blood, water, and debris, retract the tongue and cheek away from the field of operation, and reducing bacteria aerosol that's caused by the high-speed handpiece. Suction tips. Operative suction tips are designed with a straight or slight angle in the middle. They'll have a beveled working end, and they should be made of durable plastic or a stainless steel that can be autoclaved. Our surgical suction tips are much smaller in circumference and are made of stainless steel. When we position the HVE, we're going to place the evacuator before the dentist positions the handpiece and the mouth mirror. We'll position the HVE on the surface of the operative tooth that's closest to you. We'll position the tip as close as possible to the tooth being worked on. Position the bevel of the tip so that it's parallel to the tooth surface. And we're going to keep the edge of the tip even or slightly beyond the occlusal or incisal edge. The HVE must undergo daily upkeep to maintain proper working order. Specific guidelines include following infection control policies, flushing the hoses at the end of the day, checking the disposable traps weekly, and replacing if needed, and then open the saliva ejector hoses and clean or replace the screens as needed. When rinsing the oral cavity, we're going to maintain a clear operating field for the dentist, and it also keeps the patient comfortable. So we have two types of rinses. We have our limited area rinses. We're going to perform these frequently throughout the procedure, and these are going to be accomplished very quickly but efficiently. Then we have our full mouth rinses. This is going to freshen the patient's entire mouth, and this is typically done either after anesthetic and then at the end of the procedure. Our air water syringe is used for convenience and accuracy to complete the rinsing process. Guidelines include directing the tip toward the tooth that's being treated. We want to keep close distance between the operative site and the syringe tip. We'll use air on the mouth mirror continuously when indirect vision is involved. When we hear the handpiece stop, we're going to rinse and dry the site. And when completed a limited or full mouth rinse, we'll move the tip while spraying the area. Next, we'll talk about isolation of the teeth. So the criteria for isolation technique include being easy to apply, protecting the soft and hard tissue, should be relatively comfortable for the patient. Retraction provides better visualization for the operator, prevention of moisture contamination, and isolation. Cotton roll, they have their advantages as being easy to apply. We don't need any additional equipment. They're flexible, permitting adaptation to different areas of the mouth. Disadvantages include they're not able to provide complete isolation. They don't protect the patient from aspiration. They may stick to the oral mucosa if dry, may be replaced frequently because of saturation, and they have limited retraction. Next, we'll talk about our dry angle. So this dry angle pad helps to isolate posterior areas in the maxillary and mandibular arches. They block the flow of saliva and protect the tissue in the area. The dental dam is a thin, stretchable latex material that acts as a barrier when appropriately applied to the selected teeth. When the dam is placed, only selected teeth are visible through the dam. We're going to use this as an infection control barrier to safeguard the patient's mouth, protecting from accidental inhalation or swallowing of debris, protection from contamination of the tooth, moisture control, a tool to which improve access, improve visibility, and increase dental team efficiency. The dental dam is typically latex, could be latex free. We'll have two pre-cut sizes of 6x6 or 5x5. This is available in a wide range of colors from light to dark. We prefer dark though because we have contrast against the tooth. They are available in scents and flavors, and they have 3 thicknesses. The dental dam frame stabilizes and stretches the dam so that it fits tightly around the teeth and out of the operator's way. We have a couple of different frames that are available, the U-shape, the Young, and the Otsby. Some other accessories include the dental dam napkin, lubricants, the punch, stamp and plate, and dental dam forceps. Stabling methods include the clamp, and parts of the clamp include the bow, which is the rounded portion of the clamp, and the jaws, or the prongs that seat around the tooth and create the extension and balance necessary to stabilize the clamp. And then we should have a stabilizing cord. Factors to consider when application are if we're doing the procedure on the maxillary or mandibular, the shape of the patient's arch, if there are any irregularities, what teeth are going to be isolated, identification of the anchor tooth and location key of the punch hole, and size and spacing of other holes to be punched. Placement and removal for the anterior teeth, a cervical or anterior clamp may be required if the gingival third of the tooth is to be restored, and if gingival tissue must be retracted for better exposure. Stabilizing the cervical clamp, so we could use some compound. And for a fixed bridge, we're going to punch a hole for each fully crowned tooth, but we don't need to punch the hole for the missing teeth.